The first question is, what's the ideal time we should wait after crown lengthening? And the second question, can we do crown lengthening in one side only, distal area, for example?
First of all, crown lengthening is a procedure absolutely not utilized sufficiently, and many teeth are extracted because the general practitioner does not know how to do crown lengthening. A good question. First of all, I wanted you to know that every time we do root amputation, every time we do hemisection, we must do crown lengthening at the same time. And that is basically the osseous contouring at the amputation site and the osseous contouring on the remaining root. Okay, that is essential because crown lengthening is going to provide you the biologic width. You must have 2 millimeters, 0.4, okay, after the crown margin before the bone, you get to the bone. That's essential. If the crown margin's right at the bone is going to run away. It's going to resorb, and then you're going to have different problems. Now, concerning your question, so crown lengthening is a surgery, okay? And in my finalization, it comes to perio and the section on surgery in the finalization say, there is nothing called one side. Crown lengthening is on 3. In other words, it has to be involving the tooth, and definitely the one next to it. So my flap, when I do a flap, I'm doing, most of my surgery, as I told you, anterior, posterior. I'm not just reflecting the flap on one tooth. I'm reflecting the tooth on minimum tooth before and a tooth after. So you can't go, you can't go high bone, low bone. You can't do that, especially in the anterior zone. Okay, this is why we basically created the concept of anterior flap from canine to canine and posterior flap from canine to molars. Okay, this way, a small wound, one tooth wound, okay, one tooth wound or a flap heals as fast as 6 teeth flap. So don't think that if you make horizontal incision, 3 teeth is going to take more time. On the contrary, when you do quadrant dentistry, when you do dentistry next to the tooth in question, you'll find so many things, okay? And the more I do that, throughout my career, especially when I came to the Middle East, okay, scallop flaps and all of that, a lot of people, when they have dentistry or they have not taken care of them, they have diabetes, or they have also periodontal disease. So you need to get to the cervical zone. So going back to your question, no, we cannot do one side only of the tooth, mesial or distal only. Second, the reason why crown gingivectomy died, nobody does gingivectomy. A good periodontist do not do, we not prescribe to gingivectomy. You must, because if you just do gingivectomy, the tissue is going to grow back and you're going to hypertrophy and you're going to have more problem than before. You must reduce the bone associated with a problem, okay? You must do that. But so you don't have a crown, you just basically contour. If the bone is thick, you thin it. If it's thick, like the molar, second molar area, first molar area, on the buccal thick, you thin it. So you do biologic contouring, you flow. Basically the same flow, same anatomy. This is why it's called biologic contouring. You bring it back to positive issue. If it's thin, you don't reduce as much, but you still have to contour the bone. So the answer, no, it has to be mesial and distal, buccal and lingual, all right? And then how long you wait? You could, now after you do the surgery, crown lengthening or any surgery, I need you to make a provisional, lab processed provisional, good provisional, okay, to last at least 120 days. 120 days. Because after 120 days, the gingival tissue, the periodontal tissue stabilize. But if you hurry up and put the crown, the final restoration, like after 4 or 6 weeks, you're gonna have more recession, and then you're not gonna be happy, all right? Or the patient won't be happy, depend on the crown you're using, metallic or nobody use metal zirconium or otherwise. So supragingival margins, you have no problem. But if you have a supragingival margin, no problem. But if you did do the crown lengthening to go you need to wait. So in my protocol, the provisional goes for about 1 to 2 months, minimum 120 days. 120 days is maximum. But you need to get the patient back. I do the surgery. I see the patient next week to remove the sutures. And then 4 weeks, okay, put a new provisional. 4 weeks, I see the patient again. Modify the provisional, make a new provisional, and let them go. And you give them instructions, much better. All right? So that's my answer.
The second question is, what was the blue staining on the roots during the surgeries? Okay. And what is used for?
That's called methane blue. Okay? Methane blue is, it's a medical product. It's used in angioplasty, when they do it for the heart. It's available as a dye. We use it as a stain. I use methane blue. I cannot practice without it. In dentistry, in general dentistry, so anytime I have a crack, hairline crack, I have a fissure crack, and then I have fracture crack. Methane blue is a dye. You put 1 drop, 2 drops on the dentin and the crown, and then if you have a crack, it will take the dye instantly, okay? If the dye, if it's the deep crack, you see a very blue, dark stain. This is in restorative dentistry, all right? In surgery, we lay the flap, okay, you see the line, but that's enough. Even if you have a microscope, even you have magnification, it's not enough. So when you put the dye leaks penetrate wherever the crack is. So then you see the line of the crack, so you know exactly where the extension of the crack. In apicoectomy, I also use it in apicoectomy. After I remove the bone on the root end, I get to the root end, then we do bevel of the root end, so you could see the whole root, not only the buccal aspect. Then we put methane blue, rub it in real hard at the root end. You will see the periodontal ligament all take blue. So you know now that your bevel is complete. Also, the methane blue will go into the canal. Any canal orifice which is not filled, it becomes a blue dot. If the main canal, your original canal, the main canal in the endodontic treatment is substandard or leaky, it will take the dye. If the gutta percha is very good and you have cement all dry and everything okay, you put the dye, you're not going to see the blue circle. So it's basically absolutely essential for diagnostic surgery and for apicoectomy and all of that. So that's what we use. It has to be sterile. It comes, it's in the United States pharmacopoeia. It comes in ampules, okay? In ampules, it's pre-sterilized. You just put 1 drop. And I don't use cotton to apply it. You could apply it with a brush, which you use for composite. When you put the monomer, the primer, you could use that brush. Or you could use a new gauze, square new gauze, because you don't want fibers into the surgical site. So cotton is not very good. So use a brush to rub it with, or a small square, about 1 centimeter square of a new gauze that is fiber made glass. Yeah. Okay.
Third question, does the crown lengthening affect implant success if the crown lengthening failed?
Crown lengthening do not fail if they are well made. The crown lengthening does not fail if you basically done the osseous contouring and then you had the flap position cover. Does crown lengthening affect implant success? What are we talking about? Implant success, crown lengthening on implants? You mean it's next door? Is the implant next? You mean the implant next adjacent to the crown lengthening?
If you can clarify it, Dr. Athir. She said yes.
It's next to the implant. Does it affect implant? No.
Yeah, I guess, yeah.
No. No. And the question is interesting because if you need a crown lengthening next to a door implant, then that crown lengthening should be done as part of the implant placement procedure. Okay. You're looking into margin of what? Composite or amalgam? As a rule, you could be at gingiva with gold, with amalgam, not with composite. Okay? I definitely recommend osteoplasty. Okay, doctor? Amen? Osteoplasty is very gentle contouring, recontouring of the area. Yes, I prefer to have that bone level down, all right? And in those cases, this is not a complete surgery. You basically reflect what we call envelope flap, okay? Very minor, it's not a full anterior or posterior. You basically expose the buccal and lingual of the area just to allow you to insert a round burr, slow speed, number 4 round burr, and just contour buccal and lingual, and take a bone file and just file that area. By the way, very good question, Dr. Ayman. Any flap, research have shown, the minute you do a flap and put the tissue back, bone is going to resorb between 1 to 2 millimeters. So just exposing the area, you're going to have some bone desorption. And the other thing I want to tell you, I always say 2 things. I have never removed the crown and regret it, because I always find things that I did not expect. And I have never reflected a flap and regret it, because I always find things that I did not expect. Your x-rays lie all the time. Even CBCT lies. The only thing do not lie in dentistry is your eyes and your fingers when you see them direct. My concept, open and see, not wait and see, okay? Open and see. You will find things. So when you lay that envelope flap, just buccal and lingual, you see granulation tissue, remove it. The col area, the col, C-O-L, between the buccal and lingual, it's the worst area. That's where you get the inflammation, okay? You want to clean that. And if you write your margin, your cavity class 2 right there, it's a service to the patient. It will be service to you when you put your composite, you don't have bleeding, and it's a service to the patient. So basically, lay it down, and then put back a temporary, let the patient go for about 2-3 weeks, heal fast.
If I have a patient with short obturation or not ideal, no symptoms, no pain on percussion, no radiolucent lesion. Is it mandatory to redo the RCT before crown? And does the new occlusion after crown delivery increase possibility of inflammation if we didn't redo the RCT? I mean, when we decide to redo RCT if there is no signs and symptoms.
Excellent. Experienced doctor asking a good question. This is my answer. The standard of care is standard root canal, 1 to 2 millimeters short of the apex. So being short, you can ask me how. If you short and well condensed, you are okay. But short how much? 2 millimeters? Be my guest. If you are out 1 and 2 millimeters and the gutta-percha well condensed, be my guest, no problem. Okay? But if you short and weak, the canal is not well condensed, that means you're going to have micro leakage. And you don't see micro leakage in x-rays. All right? You don't. So the answer to your question is the following. No symptoms doesn't mean anything. Pain is not in my dictionary. Okay? My dictionary is biologic principles agreed on, guidelines we support. Okay? Now, the biggest answer to your question is what you're going to do. Are you going to do a post? You are in trouble. The body could go for 10, 15 years, a balance between a post, bad root canal, okay, symptoms. But the minute you go back in and open that canal to do a post, you tip the balance against the body. The sleeping bacteria get up to fight you, fight. And that's when the beginning. The minute you go back in to do the post of an old root canal, the one you described, you're contaminating the canal. And now you're going to have a flare-up. And the flare-up is not going to show the week you put the crown. It's going to show later. You could do a lot of things, and your patient leave your office, pay his money or her money, everybody happy, every smiling. It takes time to fail. It takes time to hurt. It takes time to develop region, for pulp capping to fail, for root canal to disinfect or infect again. Okay? So don't look for pain as a criteria for your practice. Look for guidelines. All right? So if you're going to do a post, my answer is do it again. But you see, doctor, this patient doesn't have insurance. This patient doesn't have money. I want to do a service. This is my answer. Take an excellent, excellent head-on X-ray. Mean perpendicular, means the film perpendicular. I want no distortion, no angulation. A good PA. And look for the lamina dura. Look for the periodontal ligament space around that tooth, especially at the apical third. If you see the lamina dura with that old root canal, with one of your description, you could venture. You could take another adventure, but no post, just a crown. Don't get back in the pulp chamber. But if you see the lamina dura is changing or altering, then to me, you're beginning pathology, but you don't see it yet. So in the course on how to become a diagnostician, I developed something called the 10 ADI, 10 ADI, 10 areas of diagnostic interest. The 10 ADI is basically looking at the pulp chamber, the canal orifice, the periodontal ligament, the lamina dura, the periapical bone, the periradicular bone, the alveolar crest, and the adjacent teeth. And you would check, 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 check. If all okay, you are fine. So my answer to you, use MTA, use super EBA, use EBA. but don't use things that resorb fast. Our IRM reported good in the literature, but it resorbs with time. All right. So that's my answer.
Okay, let's take the last question before we can proceed. Most doctors said about vertical root fracture is a hopeless tooth, so you must extract it. What's your opinion, sir? Thank you so much.
Extract the root, not the tooth. That's why we have the course today. Okay? A central, excellent question. I like to see who wrote that question. Where is it?
It's Dr. Ayman Fayoumi.
Oh, again, same doctor. Good. All right. He's asking good questions. Okay. Doctor, I have written, I also have material on the internet I have a whole series on cracked teeth. My classification of cracked teeth is, first of all, it's called line crack. What's a line crack? A line crack is a line which you take a fine explorer and run through it, and the explorer doesn't catch. The explorer doesn't catch. That's a line crack. This crack you could treat, you could do, don't propagate it, don't make it worse. If your tooth has a crack, hairline crack in the crown, or even the pulp chamber, do biologic root canal, means a single cone clean canal, no post. When you make a crown, make it sub-occlusion, smaller occlusal table. The second definition, classification, Abou-Rass, is called fissure crack. Fissure crack. What's a fissure crack? Fissure crack, if you take a fine explorer, DG16, double-ended explorer, and run it through the crack, okay, it catches, but doesn't separate. So when the crack doesn't separate, it's a fissure, all right? So run through, that one is worse than the line. The third one, fracture crack. Fracture crack. This is the crack that we're talking about. When you run the explorer, it actually goes in and you could move it and you see the segments are moving. In my interim presentation I did to you, most of the cases I saved, when I go in, I put methane blue. It takes the dye. I look at the bone on the mesial, intact. I look at the bone and the distal, intact. The lingual, definitely intact. I lost only the buccal. That means the crack is only on the buccal. Oh, by the way, good cracks, good prognosis cracks, I call them non-contributory, they never make a pocket. A bad crack, fracture, make a pocket. So in that case, we talk about vertical. If you have a pocket, like with the case I showed you, okay, there was a pocket next to it, all right? You go to the lingual, there was a pocket next to it because it's spread around. It's not IPP, it's destruction everywhere. So the crack that I'm talking about, most of them start at the apex, stop mid-root. Okay, I remove apex and mid-root. The rest is okay. That's the interim we talked about. Now, the issue of vertical oblique fractures, all right? How did you diagnose them? By surgery? Then you do the test with methane blue, take the explorer. It's 2 pieces. Of course, it's extraction, single rooted tooth. It's a molar, you amputate, hemisection that portion. The answer to that question is the pocket. If your crack, if you really have a fracture, you should have a pocket, 100%. Okay, so but if your attachment apparatus is intact, all right, and you have pathology up there, teardrop lesion or what you call J-type lesion, okay, you need to do the exploratory surgery to look at it, all right? And at that time, you're going to use the methylene blue. If methylene blue and you don't have the whole root, you could do apical or deep apical. Deep apical means you remove the apical third and just about mid-root. Okay, that's the answer. Okay, we go.
He said, can we soak the cotton in an aesthetic solution instead of placing it to dry?
For temporization? Oh, I see what you mean, for the temporization.
Yeah.
I have better for him. Again, good question. We have a good group today. We really do.
Yeah.
Okay, I know what you're saying, my friend. Okay, put your cotton, it will collapse. I know you want to pack it better. Put 1 drop of sodium hypochlorite. Okay, you want to wet it. That's what I've done that because you want it wet so it will pack. So put the cotton, rather get this new gauze. The new gauze has no fiber. And we cut them small pieces, small squares, we pack them. And you could take an eyedropper, you know, and drop 2 points of sodium hypochlorite and pack it, and then put the cavet or the IRM. So the answer, yes. But instead of anesthesia, you could use sodium hypochlorite, will kill more bacteria in the chamber. Good question. Sodium hypochlorite is your most important medication. Remove this concept of sodium hypochlorite is an irrigant. No, sodium hypochlorite, not calcium hydroxide, is your medication. That medication, there is absolute bacteriological evidence that sodium hypochlorite 5.5% kills bacteria between 30 to 60 seconds. Okay? And so if I have it in the root canal system, the root canal anatomy for 45 minutes where I'm instrumenting, I'm enlarging, I'm preparing the canal, and it's going into all the fine dental anatomy, we're doing a great job. We are basically cleaning the canal system, the lateral, the fins and the fissures in the canal with sodium hypochlorite. So I'm not irrigating anything. So I'm using it as a medication. I don't put anything in the root canal anymore. I have not done that since the 70s. We wrote an article back in 1978 about changing trends in endo, published in the American Dental Association. In 1978, doctor, we expected, Dr. Frank, Dr. Glick, I wrote the article with them. We published it in the ADA. We expected many of the things happening today, that you do not need to culture, you do not need to medicate. There's a lot of things we expected, thank God, we predicted simplification of endo. We don't want to complicate endo. We don't want to complicate surgical endo or non-surgical endo because it's a service. You know, it's something good. Something good. Extraction is no good.
Okay, Prof. The other question is, why do you avoid using calcium hydroxide in your practice?
Calcium hydroxide was used for pulp capping, so to say, to build a bridge or calcification of the pulp. Later on, there was a lot of research done in which they compared ZOE with calcium hydroxide, and some people put wax, some people put cotton pellet, some people put nothing. In pulp capping research was done years ago. I survived that period, okay? And then always the results of the research come, no significant difference. That's universal. No significant difference between group A and group B, or 1 and 2 and 3. And then later on, we found that you actually, all you need is a good, healthy pulp to recover itself. Later on, calcium hydroxide, we found that it has an ability against tissue is toxic, actually destroys cells when it comes in contact with tissue, all right? So indirect pulp capping one thing, but direct pulp capping, they found pulpal necrosis layer when it's used in direct pulp capping. And a lot of people rejected it as a pulp capping material, finished. Then came the era the Scandinavian country, the researcher, excellent researchers, there was commercial product. You could see behind many articles, there is always a commercial product trying to promote. Calcium hydroxide, then used in endodontics for epexification. They clean the canal, put calcium hydroxide to have the root end continue. In case you have a young adult, the tooth is incompletely formed, and this is called the Frank technique. They put calcium hydroxide in the canal, and they change it every week, every 2 weeks, okay, to have regeneration. The research done without calcium hydroxide, they also got the same results. The idea is clean the canal and don't let anything in them. Calcium hydroxide, so we did a lot of work also on large APCs, large canals. Then came research after that. It shows that for me, I don't use calcium hydroxide for one reason. I don't need it. I do not need it because calcium hydroxide, after 24 hours later, it's nothing but junk, powder. Calcium hydroxide efficiency only when it is in contact, it has 24 hours, 48 hours. After that, it's useless. More than that, calcium hydroxide in the canal, all right, in the canal, it creates a smear layer I cannot remove from the canal walls. I've done a course in Mexico, a surgery course. We did Apical and a lot of failures, okay? I'm really glad you asked this question. When we did Apical, failing case, we see gutta percha, and around it, a layer of what? Calcium hydroxide used as a dressing. Many times you cannot remove the calcium hydroxide you put in as a medication. It gets neutralized after 2 days, 3 days, 1 day, whatever, into the canal. So it create to me is another step I have to do. And what are you getting? That calcium hydroxide is not gonna, what kills bacteria, okay, is your sodium hypochlorite, not your calcium hydroxide. Okay, so in my opinion, it's unnecessary step. Putting in the canal walls, the apex is closed or very close. Nothing is going to happen. So what you are worried about? I'm worried about leakage from the crown. You're redressing. You should spend more time in doing good temporary, more than anything else. That's what you need to prevent pain and complication. If you do a good pulp extirpation, canal enlargement, and you don't want your patients to have pain, okay, reduce the occlusion, do a very good provisional. What I mean by that, you put the cotton or square, whatever, close it, and use temporary that do not. I have used composite so many times as a provisional between visits. Composite, because I have the material down here, the gauze, okay, and I don't acid etch, just put composite, cure it, okay. It creates a very good temporary, expensive, but we did it. So the idea of calcium hydroxide in the canal is a Scandinavian thing, all right. It's not an American thing, all right. And in terms of medication, again, my medication is what I use when I work. All right, that's the answer. Difficult to clean after you have it there. All right.
Can we use antibiotics in canals instead of using it systematically?
Absolutely not. Okay, this is what Dr. Grossman advocated in 1948. And he developed a whole bunch of antibiotics put in the canal. Absolutely, you do not need it. You do not need it, doctor. The whole idea, I used to say that, and I'm sure what's important is what you remove from the canal, not what you put in the canal. This is something we always shared with people. No, you do not need antibiotics in the canal. No. Again, I did a survey of the literature. You know, today is not research day, but actually I surveyed all the endodontics works in the kingdom. By the way, the kingdom is doing excellent job, especially on the graduate student levels. They're doing a lot of research all over the country in endo, in perio, in ortho, public health, everywhere. And I reviewed almost every article published in the kingdom. The kingdom is the first country in the Arab world in terms of research in dentistry. And that's good, that's excellent. And hopefully the quality improve. And what I'm trying to say to you, I did survey all the research done about the practices. We have big problems in root canal treatment in the kingdom. There's a lot of substandard endodontics. The percentage of apical periodontitis, according to research done in Medina Munawwara, Taiba University, they did a great job. And amazing, the percentage of apical periodontitis in that city, in that area where they did the research, was in the 60%. The incidence of lesions in endodontically treated teeth, bad substandard endo, between 50 to 60%. That's the highest number I've seen. I've seen it 40, 50%. Apical periodontitis, lesions, abscess, in normal population. If you have a patient with dead pulp create a lesion, the percentage should be no more than 1.5 to 5%. But because people are doing bad root canals, okay, the percentage of AP, apical periodontitis, associated with bad endo, all right, is between 26 to 40% internationally. You know, I studied about it in Sudan, in Libya, but the kingdom is the best research. There's some excellent periodontal research done in Jeddah University, King Abdulaziz University, Imperial. There's a lot of good surveys. So we have a lot of information available. The problem is not enough to do surveys. You need to do action. People are tired of surveys, research. You know, talk about the percentage of caries in the kingdom. Survey. We need treatment. Okay, that's what I'm trying to do. So in the endo per se, I've seen people using CMCP, they're using, is one using nothing. Out of survey of hundreds, people survey, one saying nothing, I don't use anything in the root canal. He was the only one right. So imagine that you have 100 people and only one is right. And that's I always say, you know, sometimes one is right and everybody is wrong. Unfortunately, all right? And how do you know that? Because that person, if you really look into it, you'll see that he really studied the literature and knows what works with lizards, okay? So there's a lot of practices in endodontics in the country here are old. Do you know that we used to, in America, culture, medicate, culture. Do you know why they had 5, 6 multiple visits endo? Because they used to medicate before they remove the tissue. So they put some medication in the chamber. Next visit, they remove the pulp in the chamber. Medicate again, then go to the cervical zone. As they're going down, they medicate and bring the patient. So the multiple visit endo came from culture, medicate, and be sure that culture is negative. And why did they do that? They did that at a time of buccal infection. They wanted to prove to the medical profession that dentists can make sterile canals. You never make a sterile canals. And it's unfortunate that some of these practices still available to today. And so many of these things we learned for some reasons, okay? And the message I'm trying to say to you, okay, that many practices, they complicated endo. Endo is so simple. Endo is a surgical field. You have tissue which is inflamed or dead, necrotic. You need to remove it, disinfect, and close. You could do that in 1 visit. You could do that in 2 visits. You could do that in 3 visits. You could do that in 7 visits. But if you're really competent, you know what you're doing, you could do it fast and efficient. Don't do it fast and bad. Do it fast and good. All right. And unfortunately, many of the things became commercial and so on and so forth. But anyway, I enjoy talking like that. I hope I didn't burden you. All right.
What are you working on right now? What's the plan? What's the next step for courses and programs from Prof Abou-Rass?
Oh, you know, I'm prosthodontist. I studied prosthodontics at Pittsburgh. I have a master's degree in prosthodontics. And then I didn't like lab work. So I took endo because I like biology. I like surgery. I like all of that. Then I went to Pittsburgh again for endo, completed to PhD. And then God, alhamdulillah, we came to the kingdom. Prince Abdurrahman ibn Abdulaziz, God rest his soul, Allah yarhamah. I came to the military hospital and I did this AAGD. I want the kingdom people to know that when Prince Abdurrahman did the advanced education, AAGD, advanced education in dentistry, in education dentistry, AAGD, there were 4 of them in America and the 5th was in Kingdom. They were all 1 year AAGD program in America. And we did 1 here, 2 years. So we were the first one in the world to do 2 years. That program, the Advanced Education General Dentistry, purpose was to make the GP advanced education in general dentistry, with a beautiful tone. To take a GP, who is the most important person in that team, and make them advanced, state of the art, the best in everything. We did that. We trained 170, 180. Then the Saudi Board of Restorative Dentistry started after us, maybe with a year. We came here in 1999, 2000. We started that. In that course, I found that endo-perio resto is all what's important to the general practitioner. Okay, so every general practitioner must be competent in endo, must be competent in perio. They are the foundation, and on top of that, you put resto. So that's what we are working at CASHIT to do short programs. You know, very difficult to do programs again. You know, like AAGD rules and all of that. But basically, courses in mini AAGD, which focus endo, perio, all of that. That's the backbone. This is the triangle. I call it triangle. That's the triangle.
That's interesting. Yeah.
In terms of clinical, all right? But the others is basically diagnosis. GP must be very strong in diagnosis, very strong, because they must know. Because when you talk to your specialist, you know what to expect. When you send a case, you expect it back. You need to know, what did they do? What did they do to standards? So you must know the standards of that specialty. And that's so easy today. You know, American Dental Association, everything is laid out, okay? So there's a lot of education to be done. And what we're trying to do now is do this, we're planning to put 3 months program, short program in advanced, we're going to call it the 3M AGD.
So 3 months in advanced general dentistry.
Yes, 3 months.
Great.
We're planning something like that with the Saudi Council, inshallah. Okay.
As a specialized professional program.
Yeah, this short course. Yes, definitely.
That's interesting.
Look, I'm interested in technical, clinical skills. It's nice to have a certificate, absolutely, you know. But to me, education, the content of education. Okay.